Hello and welcome to the Medicaid Insights Colloquium, also known as the MIC. Thank you all for tuning in today. My name is Jane Zhu. I'm an associate professor in the Division of General Internal Medicine and Geriatrics at Oregon Health and Science University, and I'm excited to introduce myself as the newest committee member. As usual, I'll start by going over a few quick notes for our time together today. Next slide. This session will run for about an hour, including 40 minutes of presentation, followed by 20 minutes of Q&A. Because there are many of you joining us today, please refrain from using the raise hand function. If you do have a question during the presentation, you can submit it at any time by clicking on the Q&A button at the bottom of your Zoom window, and we'll get to as many questions as we can after the presentation. I'd like to take a quick moment to recognize my fellow members on the MIC Planning Committee for their continued work in planning these events. Megan Cole is an associate professor and division director in the Division of Health Policy and Insurance Research in the Department of Population Medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. Will Shapiro is an assistant professor in the Division of Health Policy and Economics in the Department of Population Health Sciences at the Weill Medical College of Cornell University. And finally, please join me in thanking Dr. John McConnell, who will be transitioning from his role on the MIC. Dr. McConnell is a professor at Oregon Health and Science University and director of the Center for Health Systems Effectiveness. We've really greatly appreciated his service to this series. And now I have the pleasure of introducing our featured speaker, Dr. Amy Herschel. She is a PhD and the Associate Vice President of Program Implementation and Evaluation for Community Care Behavioral Health Organization, UPMC Insurance Services Division, where she leads project development and implementation, as well as program measurement and oversight in areas like behavioral health workforce development, childhood wellness, evidence-based practice implementation, and school-based mental health. Trained and licensed in Pennsylvania as a clinical psychologist, Dr. Herschel's clinical interests have focused on collaboratively developing high-quality, community-based care for children and their families. Dr. Herschel has served as the principal or co-PI for several federally funded grants, publishing on topics related to children's behavioral health implementation science, workforce development, and evidence-based practices. She'll be offering a valuable operational perspective on how behavioral health managed care organizations use data and partner with researchers to collaboratively solve system challenges to improve behavioral health care delivery within Pennsylvania's Medicaid program. Please join me in giving a warm welcome to Dr. Herschel.
Well, thank you very much for having me today. I am grateful for the opportunity to present and for that very kind introduction. As Jane mentioned, my name is Amy Herschel, and I'm currently the Associate Vice President of Program Implementation and Evaluation for Community Care. And I'll give you a little bit of additional information about community care in just a second, because it really will help with the context, I think, of the work that we'll discuss this afternoon. But I'll just mention that before coming to my role with community care, I've been in this role for about 7 years. I was on faculty at the University of Pittsburgh in the School of Medicine in their psychiatry department for a long time, and had a very nice collaborative relationship with community care. So I feel like that is helpful only because I can give you a little bit of perspective on the certainly on this side of working within behavioral health MCO, but also as being a researcher who did partner with the same BHMCO for quite a while. So let me tell you a little bit about what I prepared, and I hope that as we go along, you have questions and chat them in, because I'm happy at the end to answer any questions or thoughts that you might have. So what I prepared for today was kind of the inside scoop about a behavioral health MCO, how, and just as Jane suggested, how we use data, how we partner with academics, and how we really try to think carefully and collaboratively about program innovations and implementation. All of that, though, happens within a context, and the context in this case is Pennsylvania. So I thought it would be helpful to give you some information about Pennsylvania's Medicaid system and community care's role within it, so that we could then talk a little bit more specifically about some of the program evaluation activities that are underway, some of our academic partnerships, and then talk a little bit about emerging priorities from a BHMCO perspective. Really, what are kind of the biggest challenges that we are facing right now? So let's first talk a little bit about the context. So this is a map of Pennsylvania. I'm sure you're aware. And I'm sure when you think about Pennsylvania, you might think about maybe you think about the sports teams like in Philadelphia, the Eagles or the Flyers, or hopefully you're thinking about the Pittsburgh sports teams like the Steelers and the Pens and the Pirates. Or maybe you're thinking about the NFL draft that'll be happening just this weekend in Pittsburgh. But what you'll notice about Pennsylvania also is that it is there are a couple of key pieces of information about Pennsylvania that are important. One is that it's a commonwealth. So we are state administered and county controlled, meaning that there's a lot of responsibility and there's a lot of decision making that happens at the county level. You'll see that there are a lot of counties in Pennsylvania, and each of them is very unique. I put stars on Allegheny County and Philadelphia County because those are where our biggest cities rest. So in Allegheny County is where we have Pittsburgh, and in Philadelphia, of course, is where we have Philadelphia. In the center of the state, though, it is very rural. So many of these counties in here are quite rural. And it just means that there's a different perspective taken with those counties, or different need. They have different needs than some of our very urban counties. So that I think is all important context to have. The other point that's really important about Pennsylvania is that the behavioral health benefit is carved out. So I'm sure many of you are familiar with this concept, but for Pennsylvania, what the model, the Health Choices or Medicaid model, is really based on that fundamental foundation, which is that the behavioral health benefit is carved out of physical health and it's placed within the other human services at the county level. So that means that we talk a lot, and that's why I included this citation at the bottom. We talk a lot about human services and behavioral health integration because the Medicaid funding, essentially, I mentioned how Pennsylvania is one where there's a lot of county responsibility and decision making. So that is included here. So Medicaid dollars are really part of the county structure, and the counties make a lot of important decisions about what the individual needs are for their communities, because each county, like I mentioned, is pretty different. What that means then is that each county picks one BHMCO. So Allegheny County is Community Care, the organization I work for. Westmoreland County has another BHMCO, but all the Medicaid dollars within each county are managed by one BHMCO. So that is also an important piece of this because there's really a responsibility, kind of a built-in responsibility for each of the BHMCOs in Pennsylvania. There are 5 of them in total. But there's a built-in responsibility for the BHMCOs to be working collaboratively and aligned with county leadership within each county, because essentially the counties are the ones that hire us as the BHMCO to manage their Medicaid dollars. And they want to make sure that those Medicaid dollars are being used to really maximally benefit their communities. So all important as we talk about this, because what that means then is that we as a BHMCO have a mission, but we also have an obligation to ensure that it's not just managing money, the Medicaid dollars in and of themselves. It's also making sure that there's a responsibility to the community to make sure that that we're responsible collaborators with each of those county systems. So so I mentioned community care. So it is also part of a larger integrated system, integrated delivery and finance system, the UPMC system. So UPMC in the day was the University of Pittsburgh Medical Center. It's not real, it doesn't really go by that anymore, but it gives you a window into that we have a whole health system, a large health system, and we also have the insurance services division, all of which are part of UPMC. They just are kind of separate divisions within this integrated system. But and within the insurance services division, we have community care, which manages the behavioral health Medicaid benefit, but there's also commercial insurance, Medicare, all different lines of insurances. But how community care stands apart is that it is a nonprofit, and it is completely focused on publicly funded behavioral health services. As I mentioned, very mission driven, headquartered in Pennsylvania, but as I'll show you in just a minute, really covers a large portion of the state, and is about 30 years old, nearing the 30-year anniversary, and maintains a number of accreditations. But this is what I wanted to show you too, where community care covers the counties that are colored in. The ones that are in white are covered by other behavioral health managed care organizations. So you can see we manage the Medicaid dollars in partnership with our county partners in Allegheny, but which is a large urban. Erie is pretty urban, but then a number of these other counties are pretty rural. This represents, we have 41 counties across the Commonwealth, 67 out of 41 out of 67, 11 contracts, and you can see wherever there is a star means that we have a local office there. And I included that because it really speaks to the commitment that we are we're not outsiders to these areas. We have staff who are located in each of these areas and offices in these areas, so that there really is a strong, deep understanding of the communities with which we serve. This is just a little bit to talk about the mission and belief behind community care. So our goal really is to improve the health and well-being of the community through the delivery of effective and accessible behavioral health services. So of course, we're really always concerned about access and making sure that our members receive the highest quality services. We serve over 1 million members. I think that what will be of most interest to this group is really that how do we see research or evaluation fitting within that context? So one of the ways is through program innovations. So we really look to understand what's happening within each community, understanding the needs of the community, and then responding when there's a gap in service or when there's an identified need. And when we do that, and the response really is trying to figure out what within the collaboration, what would be the most effective and helpful intervention to implement in a community. So we have implemented things in Pennsylvania like behavioral health homes, where you have care, physical health care integrated into a behavioral health setting. We've done models with children and youth services, where we have a community and school-based behavioral health service where we partner with providers who then provide more comprehensive services through school-based delivery, particularly in some of our rural areas where that's the main place where children might seek and receive care. So lots of different program or clinical innovations, but that have been led through research collaborations, supported oftentimes by grant funding to get them up and going, and then carefully evaluated. So, one of the things that I thought might be helpful is to understand that we do have a little bit of capacity internally with community care. And part of that is because there is this strong, as I mentioned in the beginning, we're really connected. We're part of UPMC, which also has, as part of the as part of the larger system, we also have the University of Pittsburgh. And so we really are part of this culture, really, that values evidence-based practices and using data to drive decisions. So internally, we do have a team that helps kind of connect that work in and helps to collaborate with external partners. So I also put this, I wanted to let you know that there is that kind of group, but also acknowledge the hard work that this group, this is a small but mighty team. They're very effective and efficient. They do a lot. And I'll show you some of the products in just a second. But you can see that this is a team that is, we really, in developing this team, really wanted to have folks who approached whatever topic we were coming into, we wanted them to approach it with a high degree of rigor and expertise. And so you can see that actually many of them came from university labs, university partnerships. And you can see that there's different sets of expertise, from biostatistics to public health to psychology and social work, all, that are really central and critical to behavioral health. So this is the team that's internal that I have the pleasure of working with every day to make sure that we are understanding our outcomes of programs that are implemented in the community. So this isn't, some of you I think are probably really familiar with BHMCOs or MCOs where they have a quality department. We absolutely have a quality department that's led by Dr. Karen Maya, who does incredible work. This group is separate from that because this group is focused on when we have something new in the community, say we're implementing an innovation like single session consultation, they're the group that will work on an evaluation plan, collaboratively develop it with stakeholders, and then evaluate the implementation of whatever innovation it might be, among other things that they do. The other thing that they do is really try to look across our system to understand where we do need to use our own data to understand a topic better, and then write about it and develop, essentially develop a research idea around it or an evaluation idea around it, and then write it up for publication. And we do that for a few reasons. One is we do want to contribute to the academic literature. Again, it's really a value within our system. And also it is that I know there's a lot of good research out there, but what we sometimes find is that when we are trying to get into the details of a topic and really understand how we might implement it, sometimes there's not enough information on a Medicaid population to understand how it might work for that group. So we also feel this responsibility to publish what we're learning from our work so that others who are coming into similar situations have at least some lessons learned that they can draw from as well. So this slide really gives you a sense of the topics that we've published on over the last few years. We also work with our county partners and our primary contractors on topics that are of interest to them and work with them to collaboratively publish papers. Across our groups, we publish about 10 to 12 papers a year. And all of them are, papers that are community derived and that we're using either data that we have collected through an evaluation initiative or understanding our Medicaid claims data. This is I put in so that you have a link to where you can find out more about some of the publications. In case that is of interest, we house this part of our website where if you would click on this link, it takes you to this part of the website, and you can see we feature different topics each quarter. And then we have a running list of the publications that have been published since 2020. I'll say the other part about this that has been important to us is that prior to sending anything out for external review, our county partners read the work. So when you think about how to get data into practice or how to really make sure that innovations are really well understood and being put into policy and put into practice, we do make sure that before anything goes to external review, that our county partners see the manuscript and the publication or the manuscript at that point so that they can comment on it and read it. So that then I think that helps also for them to think about what we're learning from the data and integrate it within the system. They also, by the way, give us very good feedback. So sometimes it'll be a technical detail that they'll ask questions about that we'll think like, oh yeah, we better go back and address that. Or it's the content for the discussion section that they weigh in on so that we make the work even more applicable. I will also say in our evaluation projects, it has helped us to learn what not to implement or what not to continue. So we've used these studies also to discontinue activities or certainly to adjust and modify to refine work. One of the things that I thought might be helpful is to talk a little bit about some of the academic partnerships that we currently have. And this is a list that just shows you the topic, the person, and the university that they represent. And you can see essentially what will happen. You might think like, why these topics, Amy? Why not other topics? How these came to be is that essentially, as I mentioned, we work really closely with our community partners, and they'll identify a need. They'll say, we need to do more trauma work in our community, or we have noticed that we have our wait lists in provider organizations are starting to increase. What kind of intervention can we do to help shore up our system? So we'll do our homework. We'll look at we'll look to the literature, lots of research literature reviews to understand who is doing what and what might help solve the problem that's identified. And then after careful consideration with the county partners, we will decide. We usually will try to present them with options, or sometimes they have ideas about what they want to implement. And then we will decide on whatever innovation it is, and we'll look to the expert in that area and then consult and contract with them to implement whatever innovation it might be. So on this list, and so that's why you can see that some of these folks you might have, from my earlier talk, or from my earlier comments, you might have thought that we go always to the University of Pittsburgh. Nope, that's not the case. We often go to the University of Pittsburgh because we're very grateful to have a lot of resource there. And particularly, we have a strong School of Medicine with a strong psychiatry department, Western Psych, or WIPIC, some people might remember it by. We also have a great School of Social Work within the University of Pittsburgh, but we really are looking to make sure that we're bringing the most innovative work on whatever topic is identified to the members that we have the privilege of serving. And so that's why sometimes that's the University of Pittsburgh and sometimes it's others. So on this list, you can see that these partners range from, anywhere from Philadelphia to Northwestern to UCLA. So you'll also notice that they are, with each of these projects, we will have some of them, we have careful evaluation plans that are in process, but with all of them, and some of them are earlier stage of development. But with each of them, we'll have a careful evaluation plan because we hope that these interventions will have the intended effect, but we also will make sure that we're monitoring them and understanding whether they really do have the intended effect. We also, in some cases, it might not be that in terms of academic partnerships, it might not be that we have the what I just described is one pathway where we identify in the community a need, or a partner identifies the need, and then we seek out the consultation. Sometimes we're lucky and people come to us. And these are just a few examples. I just put 3 examples of where folks came to us to serve in a consulting role with the work that we're doing, and we're with the work that they are doing. And we're always grateful for this kind of opportunity because it really helps us to weigh in early from our perspective of just understanding, we have close ties with our community partners. We do have the financial perspective as a BHMCO and understand the details around what can be funded, what can't, what different financial models we've used in the past to incentivize certain practices. So we actually really like when we have the opportunity to participate on these projects because it just helps us to hopefully have a little bit of an impact. But also, these sometimes are more in our backyard. Like you'll see all of these are Pennsylvania examples because they're folks who are coming early with their work to say, we're thinking about sustainability from the very beginning. We realize that an MCO partner is a wise one to have when it comes to funding work over the long haul, not just within the grant period, but over the long haul. So so we often serve in that capacity as well to just weigh in on what might be possible versus not, because sometimes there are cases where we would really love to be able to fund something, but we can't if it doesn't meet the rules of Medicaid and the rules of Pennsylvania regulations. So it's just helpful for us and hopefully for the investigators with whom we have the privilege of working. And you can see these. One other point I think that's important is that you can see that with all this work, it ranges within behavioral health from everything from children's services, adult services, behavioral health, substance use disorders, and financial models, technology. All of those things are things that we talk about on a daily basis. Part of why we're able to do some of the work that we do is because of that. I mentioned how we're part of this larger system. And one of the groups within that larger system is the Center for High Value Healthcare. So maybe if you're somebody who tuned in today and isn't interested in behavioral health, but is more interested in physical health or social impact, the Center for High Value Healthcare, I included a link in here and just wanted to mention it because they take an even broader perspective and they do a lot of work across our system to integrate the insurance services division and that work with our health system from a research perspective. So we certainly have great researchers at Pitt on that side and in our health system, but we also have them in the insurance services division so that we can bridge those worlds. Because again, these are very big systems and you just need those bridges to help. We also, with the Center for High Value Healthcare, we're lucky to have them too because the way that our work, just how the work sits and the infrastructure of the organization means that sometimes we actually apply for grants, but we do that in collaboration with the Center for High Value Healthcare. So it most often goes through them. Certainly big federal grants go through the Center for High Value Healthcare, but they're awarded in partnership with community care and our partner counties. So these are 3 of our active grants that I included just to give you a flavor of some of the things that we are working on. And these are all examples of where we knew that there was a need in the community. And we knew that unfortunately we couldn't use Medicaid dollars to fund all the work that was needed. So we then applied for these grants, and we're lucky enough to receive them. So the first is a HRSA funded grant. That's one of their Rural Community Opioid Response Program grants. And it is for 4 years to fund initiatives to expand behavioral health services for children and adolescents in some of our rural counties and kind of the north central, top tier northern central counties. And this work has helped us to do everything develop anti-vaping campaigns to additional workforce development to trainings for clinicians and practitioners to treat problematic sexual abuse in the communities, to even a school-based prevention intervention program. So lots of good work has happened with that funding. We also have, so that's a federal grant. This middle one, the PCCD, is the Pennsylvania Commission on Crime and Delinquency. So it's a state level grant, 3-year project that was awarded for just one of our counties, Blair County, because we noticed we did a very careful community needs assessment, formal community needs assessment in that county, and realized that there were high rates of aggression and trauma in that community. And so we wrote this grant for PCCD, and we're fortunate enough to get it so that we could do more work, not just with our behavioral health providers, but with other community partners, teachers, the Child Advocacy Center, SUD supports, who were all trained, depending on which role, in different trauma-based interventions. So cognitive behavioral intervention for trauma in schools, bounce back, which is the younger version of CBITS for younger children, seeking safety, trauma-focused CDT, trauma 101, 102 for actual community members without any kind of behavioral health certification, and other trauma-based interventions. And you can see even in this that the interventions that are selected for whatever initiative we're working on are those that really have an evidence base. That's our strong first preference, unless there is something that, where there's a topic where there's not a good evidence-based practice for, but otherwise we're going to every time seek something that has a strong evidence base. And we also look to make sure that it has, there's preference definitely for something that has implementation research around it so that we can understand the best ways to implement. Of course, we always look at cost effectiveness data, and we're very grateful for the Washington Institute for Public Policy and the very sophisticated cost analyses that they do. The third grant I'll mention is the Moses Taylor Foundation that we were awarded. And this is a 2-year project where we have extended, we have an internal team that worked with partners at the University of Pittsburgh and in the central part of the state to develop our HARE, which is which stands for Healthcare Access Initiative for Recovery. And this is a community-based support where we train Black stylists and barbers in some behavioral health topics. So how to identify, when somebody might need to be referred for a behavioral health or SUD concern, how to we train them a bit more in suicide prevention and other behavioral health topics so that there's more support and training. That program has been successful in Allegheny County, but where Pittsburgh is a very urban area, and some of our other counties, but we got this grant to be able to extend the intervention to the Northeast, which is like Scranton, Wilkes-Barre area, and to adapt it to work with the Latino community. So that work is underway. And that's another example of where there was a need identified, where we couldn't use Medicaid dollars and just really wanted to make sure that we were helping communities to meet whatever behavioral health needs there might be. There's more information on those projects with this link. All right, just a few words about upcoming collaborations that we're excited about. is the one with Dr. Kelly Green. So Kelly Green is out of the Penn Center for Prevention of Suicide, and she does a tremendous amount of very community-focused implementation efforts around suicide screening and prevention. So we're going to be working with her. Part of it is driven by, we have a statewide, performance improvement plan around suicide prevention and community resilience. And so this is an example of like the state has given us this activity to do, but we want to make sure that we're bringing the best resources, the most current information, and what will be most effective for our members. And so that's why we're grateful to partner with such an expert. And so Dr. Green will help us as we prepare that plan and implement the activities so that we have confidence that what we're doing is in the best interests of our members. Another collaboration that we have coming up that I'm super excited about is with Dr. Jeffrey Wood, who's at UCLA. And he has an intervention that he developed and has an online platform for, which is called MAIA, Modular Evidence-Based Practices for Youth on the Autism Spectrum. And it is actually an outpatient delivered, typically delivered in outpatient settings, which is, I'm sure if many of you have been following Medicaid, we know that there have been really high increases in expense related to applied behavior analysis. And so this offers, and for us in Pennsylvania, that applied behavior analysis sits within a service called IBHS, or Intensive Behavioral Health Services, that are delivered in community school settings and home settings. But what MAIA offers is a way to help transition those kids to an outpatient setting when it's time for them to, with still a high quality clinical service. So we are working collaboratively with him in 2 of our larger counties to implement MAIA, and that'll be coming this fall. One final thing is, as we think about what topics are of interest to a BHMCO, we of course follow the quadruple aim. So, we're interested in the topics listed here. We're always interested in effective and innovative treatments, because we want to continue to improve the quality and clinical integrity of the care that's delivered in community settings. We also are always monitoring and carefully understanding and intervening to make sure that people have access to behavioral health care, trying to fund it in the most effective, efficient ways, and understanding that, evaluating our value-based payments, evaluating alternative payment arrangements. All of that is a big interest right now. And of course, always workforce development, because of course, all of the work in behavioral health is really because all of the work happens because we have a good workforce. And if the workforce has any challenges or gaps, that's problematic for it impacts the quality of care that people receive. So we are always attentive to the workforce, and have done a fair amount to try to infuse innovation for the workforce at varying levels, everything from supervisors, managers, CEOs of organizations to clinical care. So thinking about it on both at all levels within our provider organizations. In our training methods, when we have an initiative coming up, we use training methods that have an evidence base, like learning collaboratives, to ensure that we're reaching different levels within an organization. If I had to think about what are the most pressing topics right now, one of them would be care for children with ASD, and applied behavior analysis, making sure that kids are getting the care that they need, but then transitioning so that we don't have wait, so that there's system flow, so that we are making sure that all the children who need that care get it as early as they possibly can, and get a good dose of it, and then go to whatever might be the most appropriate next step for them. In terms of collaboration values, as I hope you have heard throughout the time that we've been talking, there really is a strong value placed on collaboration across stakeholders. So, community partners, academic partners, whomever it might be, we really value that kind of collaboration because we know that the challenges that we experience are complex and they need the best thinking and the best thinkers that we can bring together to solve those challenges. And of course, always incorporating the voice of service users and families. So we actually internally even have infrastructure where we have committees and stakeholder groups that we will take, whatever is of whatever topic we're working on, we will take it through different stakeholder groups to make sure that before something goes to the community, that is something that actually, from their perspective, will be helpful. All right. So I will leave it at that and just say thank you very much. I really appreciate the opportunity to talk about this work, and I would love to take any questions.
Great. Thank you so much, Amy. We're going to wait for some questions to come in. I will just say, MCOs are almost a black box to a lot of us researchers. We really value the work that you're doing, but we don't have a good window of visibility into the projects and the efforts that you engage in. So I really appreciate this overview. I'll start with some questions. You mentioned that you do a lot of collaborations with researchers. I think Medicaid researchers are very familiar with approaching states to work in partnership.
Mhm.
What might be different about working or approaching MCOs and working with them? How do you think MCOs think about research priorities that might be different from what states are doing? And then can you just comment on whether you think sort of your values in your organization around research and collaborations might be different? How might that vary across MCOs? Are all MCOs as open to working with data as you are?
Those are great questions. So, sounds like the first one is really the MCO perspective versus the state perspective. Excuse me. And I would say, certainly there's going to be alignment when it comes to state priorities because we are following very closely so for example, for us, we're attending all the state meetings, we're trying to understand what the state's priorities are, we're aligning our organization that way. We're also aligning with all of our county partners who may or may not have the same priorities as the state. So I think when you're partnering with a BHD-MCO, there is some overlap, but I would say the differences are around, I would say some of it is like for us, it's really the tailored to the communities. So we're looking community by community. And I think it's the financial sophistication and understanding how the Medicaid dollars flow, how we can make things work, and where we really are um, where there's really a barrier related to regulations that we can't change. So I think that um, is where the BHMCO partner can be pretty helpful.
Can you tell us a little bit more about I think, in terms of behavioral health workforce challenges and what are your findings around that? Sort of insights that the broader public or researchers might not know. What's preventing programs that are working with your MCO from being scaled more broadly?
I would say workforce is so complicated and so tricky. Um, we've done different initiatives. Some of it I think is when you think about the different levels within an organization, um, the managers, supervisors versus the leaders in the organization versus the frontline staff. Those are all different levels within an organization that have to be attended to. And so we have done everything from, during the COVID pandemic, we had a series, a collaborative series with organizational leaders where we brought them together to talk about some of their, like over the course of a 9-month engagement, where we would offer some content. This is one where we partnered with Penn State Smead School of Business, where they would offer content about, how do you lead through change? How do you evolve in this kind of climate? How do you attend to the workforce and ensure psychological safety for leaders, all the way down to doing interventions with lots of clinical training with frontline providers. But I think all of that really does still rest on the fact that you need the kind of workforce pipeline. And so that's where we also will partner with some of our academic institutions to help that pipeline along as best we can. And where I think I mentioned in that HRSA Grace project, we have developed an intervention along with a community organization to introduce behavioral health topics to high schoolers. Because when you think about the pipeline of where folks, how they get to even making decisions about where they're going to go in the workforce, it's at a lot of times people give content in college, but we thought, well, let's try to do it a little bit earlier on. So we've developed curriculum in partnership with, they're called AVITM clubs, which are school-based clubs. There are a lot of them across Pennsylvania, where it's kind of a group that is already interested in behavioral health and social services. And so we have infused some additional curriculum there to help. And I'm just giving little examples or snippets of how we really have tried to collaboratively develop a more comprehensive approach. Many of our county partners have done even more, where they've offered tuition reimbursement and incentives to help fill in the service lines where they need the most staff, where they have more turnover. But it is something that we're always attending to, always working on. We recognize that some of the services that we have are really reliant on a master's level professional, which I'm sure from academics sounds like, oh, that's not difficult, but it really is difficult in some of our communities, particularly some of our rural communities, to staff those. And so we're careful to think through administrative burden on those master's level staff, because we want to think about how they can be using their clinical skills to the highest degree, not, we're really working at the top of their license rather than doing a whole lot of additional paperwork or things that would burden them.
Can you give us a specific example on that?
Mm-hmm. Yeah, so we had an intervention called Top Care, where we worked with folks to figure out what the administrative burdens were they were experiencing, so that we could understand which of them really were regulatory, that had to be part of what they were doing, versus what was maybe kind of historical or institutional, like that maybe wasn't really as current as it need. Maybe there was there were some things that they were doing that weren't really quite as necessary on the administrative side. So we've done things like that. We will sometimes have alternative payment arrangements when we know that there's a service that there's a high need for. Let me give you an example. So we have a community and school-based behavioral health, and in that service line, it's located in schools, and so we contract with a community-based behavioral health provider. They're located in a school, and they're located in schools where there's a high Medicaid population. And then they provide not just clinical care, but coordination with school personnel. They provide care management activities, and they really serve as this kind of all in one. They manage crisis situations. So because they're doing all of that, we have developed with them an alternative payment arrangement. So they're not fee for service, it's an APA, where they're then able to do all of that work and not have quite as much burden as if they were doing fee for service. And they're able to do then a little bit more because that little bit more is really what meets the needs of that community. Like, for example, within it, there's a requirement around assessing social determinant of health for children and their families, and then referring them to contracted community-based organizations.
Mm. That's very interesting. Just moving back to sort of the state context that you talked about in Pennsylvania, a lot of states have now moved towards carving in for behavioral health services, and Pennsylvania is one of the holdout states. Can you
Yeah.
talk a little bit more about, what if that's likely to continue? If so, why? And how might the incentives for a Medicaid managed care organization like yourself change when you're considering carve-in versus carve-out arrangements?
Well, I think it goes back to a question that you posed that I don't feel like I answered, which was the how our values align with maybe other BHMCOs or other MCOs and how they may or may not be different. And I think part of the culture that has been built has been, and that's why I mentioned early on and showed you the map of Pennsylvania and talked a little bit about Pennsylvania as a human services integration model, and mentioned the carve out, is because I do think that a lot of what we do is within that context and because of that context, because we are aligned with the county structure where we come in with, instead of physical health, all the other human services. So child welfare, juvenile justice, all of those are what the county is working with or working. All those rest in that system. So that's why Medicaid dollars in behavioral health rest in that system. And so I think because of that, and I think a little bit because of how community care developed over time and is a nonprofit, it has encouraged that local focus, understanding the communities in which we live and work, and having this responsibility to those communities. And so I don't know that that would be the case. I don't know that it's fair for me to say, but I don't know, given the role in which I sit and the bias that I have, but I don't know that it would be the same if we didn't work within that context. We really, really put a high value on partnerships and collaboration. And I think it's because that's how we all work together to meet the needs. Does
Thank you
that
so
make
much.
sense?
Yeah, I think so. I want to give space for others to ask questions, but I don't know if people are seeing where to do that. So I just wanted to interject for a second. Under the new Zoom interface, your Q&A option might be under More. And so if you want to ask a question, please go ahead and type that in. If you're having trouble finding that, please let us know. But I want to make sure that the Q&A is open. Okay.
And as you're looking at that, Jane, I'll just say that the other thing with the carve out, I think, is people would be understandably concerned about the physical health. Well, if you're so focused on behavioral health and integration within human services, then what about physical health? And so I think there also are guardrails that are built into the system to ensure that physical health is attended to as well. So one of the things I mentioned was our behavioral health home models, where if folks are already going to a behavioral health center for their care, we have then, instead of, you often hear about, primary care will have therapy delivered, behavioral health therapy delivered in a primary care office. We have looked at it the other way, where maybe if you have somebody who's going to community-based behavioral health center for their behavioral health care, we can embed physical health within that setting as well. So I think you see a lot of those kind of models, collaborative care models, because we do have the guardrails and pay attention to integrating within physical health as well.
And to what extent do you interact with the physical health, the comprehensive managed care, or the physical health managed care organizations that are in Pennsylvania to oversee your joint enrollees?
Because we're part of an insurance services division, there are a number of our members who, and so within the UPMC Services Division, there is, community care, which is behavioral health, but then there are other commercial, Medicaid, and physical health benefits. So part of it is through that, but then it's also working through the detail at the ground level. So that's one way. There's other partnerships that we have with other physical health MCOs. And then at the client level or at the consumer level, there are integrated care plans that are developed that cross over.
Got it. Um, we only have 1 minute, a couple minutes left for questions and to close out. But I wanted to ask one sort of hot topical question, which is around autism services. You had brought that up earlier. Can you tell us a little bit more about the challenges that you're facing there, both with, sort of meeting needs, but also we've been hearing in the news about um, uh, the lack of regulation in this space. Can you tell us a little bit more about what you're observing in the autism ABA services area and what some of those challenges might be?
Mhm. It really is that we have seen and have been carefully following some other states where there has been this dramatic increase in funds spent on applied behavior analysis. We have seen the same pattern, but not quite as big of an escalation in cost. Certainly an increase for sure, but not at the same rate or level that some of the other states are experiencing. And I think it is, the other thing that we have that other states are not experiencing is that there was a big policy shift in Pennsylvania in 2019. So it impacted in 2020, where we went from one set of regulations in the level of care where ABA or applied behavior analysis is delivered to a whole different set of regulations. And those set of regulations really were around making sure that children who needed ABA got it. So I think that the challenge is real to make sure that kids are getting the care that they need and that we also are not, that we're responsible with the dollars that are available to treat the whole population. So it really has been a careful analysis to understand where we can manage that in the most responsible, clinically effective way. And that's why we're thinking about interventions like the one that I mentioned, Maya, because it is something that adds to the system that also should help that flow through the system. So kids get what they need and then they go on to another service that will still give them good care, but isn't quite as intensive as applied behavior analysis.
I have so many other questions, and I'm sure our attendees do too. But unfortunately, we are out of time. I want to be mindful of time. Thank you so much for joining us today, Dr. Herschel, and thank you for joining us as well to our audience.
Mhm. Thank you very much.
So I just want to make an announcement about the next session. You'll be receiving a 2-question survey about this session, and I hope you'll answer it to help us continue to make this program better. We'll see you again when we resume this spring with a Wednesday, June 17th session with Samantha Artiga, Senior Vice President of Kaiser Family Foundation and Director for Racial Equity and Health Policy. Artiga has also conducted extensive work related to the health and healthcare needs of low-income populations and previously served as Associate Director of Kaiser Family Foundation's program on Medicaid and the uninsured. So don't miss that. Make sure to stop by and RSVP at the series website, MedicaidInsightsColloquium.com. Thanks again and have a great day.